Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest instalment of video interviews for Medicine Journal. I'm Albert Ferro. I'm the chairman of the editorial board of Medicine, and I'm delighted to have with me Dr. Safa Al-Shamma, who's been with us before a few months ago for the hepatology issue, and this time he's here to talk about the gastroenterology issues, which run from this month, February, till May 2024. Safa, you're very welcome.
Thank you very much. Thank you for inviting me and having me again.
Okay. And at the risk of repeating yourself, perhaps just tell us a few words about yourself before we dig into the interview.
No problems. Yeah. So I'm a consultant gastroenterologist and hepatologist. I've been at the Royal Bournemouth Hospital, which is part of University Hospital Dorset, for the last 13 years. In fact, it'll be 13 years to the day tomorrow.
Oh, happy birthday.
Anniversary of that, yeah. So I'm getting all these LinkedIn congratulations randomly from people that I've not heard from in years. But anyway, so I do a lot of work with the college, and I'm grateful that you've invited me to be on the editorial board with the journal. And I do a lot of work with the Royal College Examination Boards, the Part 1 exam and the Specialty Certificate exam. And I'm also for my sins, the secretary of the British Society of Gastroenterology as well, which means I'm responsible to help coordinate the annual conference meeting and the educational program and webinars and so on.
Good. So you're a busy man. And the reason we've got you here is because you're the editorial board member who's overseeing the gastroenterology issues. As I said, there's 4 issues: February, March, April, May 2024. And what I thought we might do is touch on some of the topics that are going to be in the issues, but we might also touch on other things that aren't in there, which are of interest and topical. And I have to say that what we'll talk about today won't be exhaustive. There's a lot more, and I'll direct people who are watching this to the actual issues. But we're just going to have a bit of a chat about some of the things that might be highlighted in the issues. And the first thing, perhaps, is inflammatory bowel disease. Obviously very important. But I wonder if we could start maybe by you, Safa, telling us a bit about inflammatory bowel disease, what it is, how it presents, and the standard treatments, that sort of thing. There's a wide-ranging question for you.
Yeah, sure. Inflammatory bowel disease really encompasses ulcerative colitis and Crohn's disease. Ulcerative colitis is an inflammatory condition generally restricted to the colon. Crohn's disease can affect anywhere in the alimentary tract from mouth all the way down to the anus. And again, it's an inflammatory condition, not to go into the details of it too much, but there's clearly a genetic predisposition in some people, but also there are clearly environmental factors that would then increase your risk of developing these conditions. As an example, could be use of antibiotics, or it could be some types of infection that we get in younger childhood that may be of influence, but we don't know the exact sort of causation. And other environmental factors, for example, smoking is an interesting one because in people who have Crohn's disease, smoking makes the condition worse and makes them respond less well to treatment. And that's in distinction to ulcerative colitis, whereby smoking seems to have a protective effect against getting ulcerative colitis, and also it makes the disease respond to treatment, or it settles the disease down. It's an interesting contrast, I would say. So in terms of the frequency of these illnesses, we are probably diagnosing more of them, with not a huge increase in the numbers and the prevalence, but there is a gradual increase in that we're seeing. And treatment-wise, we've certainly had, I would say, maybe not a revolution, but a very rapid evolution, especially in the last few years, in how we go about managing patients with IBD. It remains a case that we need to have a colonoscopy for most patients. Obviously, Crohn's disease, it may affect the small bowel or the foregut, but often it does involve the colon in some way. So we have a colonoscopy and we identify it either by the endoscopic and biopsy findings, as well as a clinical picture. Steroids have been the mainstay of therapy, and to an extent they still have a role, especially in ulcerative colitis, but we're really trying to move away from using steroids in Crohn's disease, not least because of the side effects that we get. And whilst they can be effective, they're generally short-lived effects. Once you wean them or stop them, the disease can often recur. We also use 5-ASAs, so mesalazine-type medication. There's evidence of efficacy in ulcerative colitis, but not in Crohn's disease or Crohn's colitis, where we don't use them anymore, generally speaking. And until really, about a decade and a bit ago, 12, 15 years, that was all we had really. And then the biologic agents came up, infliximab and adalimumab, and they were very much revolutionary, especially for severe disease, severe colitis, and they've changed the options that we have. And these anti-TNF medications do carry their side effects, and they were very expensive. Then came the era of biosimilars, whereby these drugs are generic in effect, and they've become a lot more affordable, so we can much more easily use them in our patients without having to jump through hoops as we had in the past. And then that was that's been around for a good number of years. There was initial concern that biosimilars were not as effective as the originator, but actually that's not found to be the case. And then over the last 6-7 years, we've had new agents, because before, once you exhaust the anti-TNFs, you sort of run out of options. But we've had new agents in the form of interleukin-23, ustekinumab, and then vedolizumab, which is an anti-integrin against lymphocyte trafficking, alpha-4 beta-7. And that's proved to be very helpful. So you have more options for the patients who get antibodies or lose response or don't tolerate the anti-TNFs. And then again, that was we had 3 or 4 options. They're effective, but, that's the limit. Until the last 2 or 3 years, we're really seeing almost an explosion now of new therapies. One of the things where we've lacked is good, effective oral treatments, but we've got the JAK inhibitors, so Janus kinase inhibitors. The first generation tofacitinib had concerns about the side effects being a pan-JAK, particularly VTE risk and cancer risk. But fortunately, we've had newer agents who are more JAK selective against JAK1 and 2 and 3 subtypes, and particularly upadacitinib seems to be very effective, well tolerated, fast acting. The side effect profile, we'll still need to figure out exactly how it behaves in real life, but we're certainly getting good results in our patients, and we're increasingly using it. So now we have an oral agent that's a small molecule, not the same problems with having biologic treatments that could give you antibodies and so on. And then going forward, going forward, actually, we do have a plethora of new drugs on the way. New interleukin-23s, mirikizumab and risankizumab are both new drugs, newly approved, are likely to prove very effective. The ustekinumab is going to become a biosimilar, so that could also increase our access to it. And there's a multitude of new agents, so newer JAKs and newer oral agents, new pathways being explored about treatment. So I think in the next 5 to 10 years, there's going to be a significant, especially in the next 5 years, really significant ongoing evolution in the treatment paradigm that we have. Of course, the old adage is if you have lots of medications for a condition, none of them are particularly good. Hopefully, we'll find 2 or 3 that will prove to be very effective, well tolerated, and they become their sort of go-to medications that we use for the vast majority of patients. And we have better ways of predicting who's going to respond, and we target the therapies better. So I think. And for our patients who are now struggling, the more difficult ones, we also have hope to offer them that there are things around the corner coming up as well. Because in the old days, once you run out of options, it was surgery, and we used to see surgery as a failure or a defeat. And we still might find there's a role for surgery. Some people do very well with that, but I think with the change in the way we're approaching treatments, that's going to be less and less of an issue.
So it sounds like there's been real advances in the field, especially with the newer biologics and the newer oral small molecule inhibitors. Can I just ask you, at what stage would a patient now be started on a biologic, let's say one of the biosimilar anti-TNFs? Would they be started at quite an early stage, or do we still rely on the old style, steroids, other immunosuppressants before going on to?
And I didn't mention immunosuppressants because actually, in a way, I wouldn't say obsolete, that wouldn't be the right approach to them, but they are being used less and less, perhaps used with the anti-TNFs to reduce antibody development. I think the approach is certainly focused much more on escalating more rapidly. Some people even go with the top-down approach, where you start almost straight away with anti-TNFs. Some people take that on, others less so, whereby you'd have maybe a low, but most people now have a much lower threshold for starting anti-TNFs. Clearly, you have special groups, people are more risk of infection, more elderly patients with previous cancers, where you may wish to avoid anti-TNFs, and this is where these new medications come into their own as well, where perhaps you can, circumvent going through the anti-TNFs and go through the other agents. But you're right, in terms of where we start them much earlier in the sort of disease process, rather than waiting for multiple courses of steroids or a hospital admission or a severe flare before deciding to start them.
Okay, thanks very much. Let's turn to another area where I think targeted therapies have really made a mark. And that's in GI cancers. We might talk about upper and lower GI cancers, but taking upper GI cancers, first of all, in my day, of course, it was surgery, radiotherapy, chemotherapy. But I think, again, this is an area where we have more targeted treatments now. Could you tell us something about that?
So yeah, there's definitely been a change in the paradigm of treatment of GI cancers. Perhaps not quite to the same. So immunotherapy is essentially what's revolutionized oncology, the field of oncology, immunotherapies. And I think, and obviously I'm not an expert in immunotherapies by any stretch of the imagination, but they have had let's say, a modest benefit in GI cancers, not perhaps the game-changing sort of outcomes that we've seen in melanoma, for example, whereby people who have metastatic cancer can effectively be cured, or some lung cancers or kidney cancers with these immunotherapies. But I think this is a stepwise progression in the right direction, particularly for some upper GI cancers, stomach or esophageal cancer, whereby, for metastatic disease, there's definite benefit for the immunotherapies, pembrolizumab, nivolumab, and the newer mAbs coming online as well are likely to find a role in the GI cancers, which have, unfortunately, had historically poor prognosis and poor outcomes, and especially because most of them present at a stage where it's too advanced for surgery, and surgery does remain the best chance of getting a cure from your upper GI cancers. And if you're beyond surgery, then getting a good 5-year survival remains fairly poor. And pancreatic cancer, for example, is one of those cancers where we really haven't quite achieved where we want to be. But even there, in one of the, I would say, probably the worst cancer there is, pancreatic cancer, in terms of prognosis and outcome. Even there is some hope of newer therapies coming into play, more targeted therapies, so cell therapies where we really try and target the cancer, but also potentially a role for vaccine-type treatments as well for pancreatic cancer. Mm-hmm. In terms of going back to some of the GI cancers, liver cancer obviously is not upper GI per se, but in terms of what we've seen with immunotherapy, we've recently had approval of atezolizumab and bevacizumab as a combination for first-line treatment of liver cancer with really good outcomes compared to what we had previously, which was only sorafenib, and we had sorafenib for over 10 years as the only chemotherapy agent we have for patients who are not suitable for other local regional therapy or transplant with liver cancer. And sorafenib, tyrosine kinase inhibitor, is a drug that has its significant side effects and tolerability issues. It does work, but it does have side effects. So it's good that we have newer treatment options to offer these patients as well on top. So I don't think I can say that immunotherapy has revolutionized the management of upper GI or hepatobiliary malignancy just yet, not in the same way as I said, melanoma, for example. But I think over time there are newer therapies coming online. Another thing to bear in mind as well is the side effects that we're seeing from increased use of immunotherapy in other cancers, because GI side effects is quite common, particularly diarrhea and colitis. And we're seeing more and more of that. Hepatitis, biliary cholangitis as well can happen. So again, that's the sort of thing that as gastroenterologists, we're having to get ourselves more familiar with, managing and assessing and evaluating. The oncologists are very good at managing these without involving us. So they only send us the hard cases. And of course, we only see the hard cases very rarely because they manage most of it. So it makes it even more of a head scratcher as how we approach these patients, and the role of an MDT and discussion with colleagues becomes even more important.
Are the considerations that you've talked about, are they similar in lower GI cancers as well? That there's been some advance, but again, not game changing?
Yeah, I think that's right. I think lower GI cancer, colorectal cancer, in terms of prognosis and response to therapy, is definitely better than upper GI cancers. And I think the biggest advantage with lower GI cancer is that we have the ability to detect it much earlier compared to upper GI cancers, where we don't have a screening program in upper GI cancers like they do in Japan, which is a very, very well developed, stomach cancer, because it has such high rates and they've really improved prognosis. We simply don't have that. We have, you've got 5-7 minute endoscopy in somebody who's unsedated and might not tolerate it very well. We're not going to pick up the precancerous areas that we want to stop them getting gastric cancer. Colonoscopy, on the other hand, we've had huge improvements in how we deliver colonoscopy. The standards as met by the sort of national body overseeing that in JAG has improved. There's endoscopists having assessments of the polyp detection rate and so on, to ensure that they're delivering high quality. And that's how we prevent cancer developing, or we catch cancer earlier as part of bowel cancer screening program.
And speaking of the bowel cancer screening program, because this is something dear to my heart, because I fall into that age group where we do get offered regular screening.
I'm not far away yet.
But the regular colonoscopies are not part of the NHS program anymore, and what we're offered is fecal immunochemical testing every couple of years. I'd just be interested in your views as to whether that's a good thing, whether that, I mean, it's obviously more convenient to a degree for patients to do that rather than undergo colonoscopies, which many people might not like the idea of. But I wonder what your view is as to whether it's as effective in picking up colorectal cancers.
So I think in the UK, there's never been where you were offered a full colonoscopy as a screening, as a purely screening national program. You get offered a flexible sigmoidoscopy at a certain age, and then if you have that's looking at the distal part of the colon and remove any polyps. In America, they offer a full colonoscopy as the method of screening. But like you say, that is invasive, it's not necessarily convenient, and the uptake might not be very good because patients don't want to have a colonoscopy unless they really have to. Therefore, the FIT test comes in, and we used to have FOB, fecal occult blood, before, which was sensitive but not quite sensitive enough. The FIT test is a more sensitive way of detecting blood, and actually we find the sensitivity is certainly good for cancers and for advanced polyps or polyps that are larger than 1 centimeter if it's done properly. And of course, there still is that potential barrier of patients doing the test, whether they don't like doing it or whether they are able to do the test for whatever reason. And so increasing the uptake of the screening will definitely detect cancer. So I think in terms of a halfway house and it's probably adequate, as probably does a good job. And the evidence suggests from all the national programs that it does prevent and improve outcomes in distal cancers. For proximal cancers of the colon, it's a bit more debatable as to how much benefit there is. And that's probably because the nature of proximal colon cancer is different. They're easier to miss. The bowel preparation is less good in the proximal colon, so things are easier to miss as well as part of a colonoscopy screening. But certainly for distal colonic cancers, there's evidence that FIT and then colonoscopy will save lives in essence, and that's why it continues in this current form. And on the convenience issue, there is some developments in endoscopy. The pandemic, where we were trying to avoid doing invasive tests, there was an increased use towards capsule endoscopy. So we have capsule endoscopy, looking at the small intestine, where you swallow a capsule has a camera and you record it. But we've developed that to include capsule upper GI endoscopy to look at the stomach, and also capsule colonoscopy as well, something that is being progressively developed, and there's studies looking into how that can be delivered and how effective it is. But it's certainly a less invasive way of being able to assess the colon. Still will require prep. Obviously, you can do interventions. If you find a polyp on it, for example, you still need to bring them back for a procedure, but it might be a reasonable starting point. I'm not suggesting that's going to replace bowel cancer screening. Mm-hmm. That may never happen. It may take many years before we have the capacity and the sort of technology to be able to deliver at such wide scale. But we do have ways in which we can make colonoscopy less invasive. We had CT colonography in the past, and that's also a reasonable approach to screening as well. If somebody did have a colonoscopy, for example.
I want to, sticking to the subject of colorectal cancers, ask you your opinion about another subject, which is, again, kind of close to my heart, and that's aspirin. And I'm interested in it because of the cardiovascular benefits, and that's my area. And for a long time now, there's been a lot of interest as to whether aspirin might have a role in preventing colorectal cancer, or preventing its spread or its initiation. And I'd be grateful for your views, your input on what the current state of play is with that. Is aspirin should the whole population be on aspirin is I guess the question. That's what people ask me about, the heart. Should everyone be taking aspirin to prevent heart disease? And the answer is no, because if you're at low risk, if your cardiovascular risk is very low, then benefits are outweighed by the risks of bleeding and so forth. Perhaps you could just tell us what you feel about the state of aspirin in preventing colorectal cancer.
As it is in cardiovascular, it seems. So the answer is no. There is no evidence that for an average risk person over a whole population, that given everyone aspirin is going to reduce the risk of getting cancer or polyps. But in those in higher risk, such as patients who have Lynch syndrome, which is a sort of non-polyposis increased colon cancer, there might be some benefits. There is also some potential data suggests that if you've already had polyps, it may reduce your risk of getting more polyps. But in terms of data to suggest for an average risk person whether they should be on aspirin to prevent getting colon cancer, then the answer is no, there really isn't evidence. And I suspect that even if there is a small benefit, it would be outweighed by the GI bleeding side effects that you get with aspirin. So on the whole, it's not something that's in routine practice recommendation. Mm-hmm. Of course, there's the occasional patient who takes upon themselves to take aspirin to protect their heart.
I think we've pretty much run out of time, Safa, but it's been a really interesting conversation as always. So thank you very much once again.
My pleasure. Thanks very much.